Oral vancomycin therapy is initiated and the patient's diarrhea resolves. However, 4 weeks later, she returns to the office because the diarrhea has recurred during the past 4 days and she is again having 5 to 6 bowel movements daily. What is the most likely reason for this patient's continued condition? I'd love to hear from the students on your approach to this part of the case and what you were thinking as you wrote your answers.
So I see that she returned to the office with recurrent diarrhea, and the frequency of the diarrhea occurred 5 to 6 times a day. When I look back at the first part of the question, it's about similar frequency. This first paragraph is 6 to 7 times, but I'm conscious of whether it's the same disease that the patient had in the first part of the vignette, which is why I think it may be some kind of resistance. I also would want to know whether the patient took their full course of antibiotics.
How many different types of knowledge do you have to bring to this case to answer this correctly? You have to know about the microbiology of Clostridioides in this case, and spore formation, and how that acts in the bowel and how it may not be cleared. You have to know about pharmacology and antibiotics and how they actually operate on a bacterium, right? So vancomycin and that class of antibiotics typically are bacteriostatic, not bactericidal, and so that could change the clinical response or what we might expect. So this is a really nuanced situation that requires a lot of different skills to get to the bottom of it. Let's see what the red flags we felt were here in this case. And obviously the recurrence in the past 4 days and continued diarrhea. So which of the following is the most likely reason for the patient's continued condition? A, patient non-adherence with the initial treatment regimen. B, recurrence of infection with the same organism. C, reinfection with a similar organism from human contacts. D, resistance of the organism to the initial choice of antibiotic agent. Or E, underlying decrease in host resistance. As we're doing this, I'd love to hear from any of you about how your approach changes now that you see the answer set, because we did have not as much agreement with each other on your written answers. Any thoughts?
One thought I had was that when the answer isn't as clear before you see the answer choices, you never know if you're slipping into one of the kind of alternative diagnosis, like traps, if you want to call them. And then when you do see the answer, it's like, do I just side with myself, or you really have to like take the second and read through the answers again and think about the course, make sure you weren't falling for like a similar diagnosis situation.
That's a good example of higher order thinking skills to get through some of these questions for sure. Any other thoughts?
I think this one is a little bit harder than the last one because things like pharmacotherapy, right? There's like a much narrower set of specifically correct and incorrect answers. And this, honestly, I read and I went with A, but I was also thinking maybe D is something that I would consider too. So it might be the sort of question I could narrow down to a couple choices I liked and then just have to go with a gut reaction on that.
I also agree. I feel like this question is definitely harder, and I was also between A and D. Initially, my first thought was, when I read the question, was trying to decide, is this a new problem or the same problem? And I figured out, well, I think it's the old problem. So that got me down to a few of them, but I think it's a lot harder in trying to pick whether, without it saying if the patient took all of it. I don't know that I feel comfortable saying that maybe they didn't take all of it, but I also don't know what the resistance patterns of VANC is. So that's trying to make a gut decision based on that.
Yeah, I liked a few of the answer choices and I really wasn't sure. I tried to look back at the timeline. So 4 weeks later, she returns and it has recurred. And if I knew more about the timing of like resurgence of symptoms following antibiotics based on if it's reinfection or if it's incomplete treatment, then that would help me more. But yeah, I still wasn't sure at the end.
And I noticed for some NBME questions, sometimes two answers could be possible. And I look at how they frame the question. In this case, it says the most likely reason. So it also has to come down to, you know, what's the more frequent answer? What's most likely to be the reason, even if two of them are possible?
What exactly are they asking me to answer here? And we often see, even in our studies, that students will first read that lead-in, just like you said, David, and then try to hone in as you look back through the information on exactly what it is the answer should be. Because like you say, you may get this down to one or two, maybe even more, but there's only going to be one key correct answer. So
I was paying attention to kind of like the 4 weeks later and thinking about if this was a recurrence or non-compliance, or I guess non-adherence. Would it take 4 weeks to then build up again, or would it be a shorter amount of time? But then when I see the most likely reason as the prompt, in my mind, patient non-adherence is much more common in the general public than resistance, unless this person is consistently in like the hospital's systems. So to me, it was hard to choose between A and D for those two reasons.
great, thank you for the comments. First, we're going to see what your responses were. And looks like most people went for D, resistance of the organism to the initial choice of antibiotics. And a few people went for A and B, so non-adherence with the regimen as well as recurrence of infection with the same organism. Let's see what the correct answer is. So recurrence, B was the correct answer.
To me, this looks like a patient who underwent some treatment and the issue completely resolved, right? So the item says the diarrhea resolved and then it recurred. When I take these tests and kind of when I look at these questions, is it fair to assume that patients that are represented in these questions are adherent and compliant unless said otherwise? That's always kind of something I have assumed. And so since the diarrhea resolved, I'm thinking about D, and if there was resistance, I'm not sure that the infection would have resolved, especially understanding that vancomycin, if there were resistance to that vancomycin, I would expect there to be some low level of diarrhea. That's just my thinking. I'm not sure if it's correct thinking or logical thinking or not. And I would have gotten to B here to choice B.
I will divulge that this is actually probably what you would consider a step 3 level question. So you might argue it's a little bit more challenging. And the wording is sometimes difficult to tease out. What's the difference between reinfection, resistance, and recurrence? And in this case, recurrence happens usually 8 out of 10 times when there's a relapse of symptoms. It's going to be a recurrence of infection. And it has everything to do, again, with what Clostridioides does in the bowel. Lots of people are walking around with Clostridioides, but they're not having any symptoms. And then lots of people that have been cured of their infection still have spores. And then given the right circumstances in the bowel, there can be a recurrence. And that tends to be the case in these patients. About 1 in 4 of these folks will have a recurrence within 30 days from the same organism, as it were.
In the back of my mind, there's still a question of whether or not there could be a resistant organism. Perhaps you have, really cut down the bacterial load to a point where it's non-symptomatic for a period of time, but yet there might be that one little, resistant strain that has taken a while, that has still had a foothold and has taken a while to then express itself symptomatically.
Yeah, that's a fair point, and it makes me think back to the idea about, well, how do we really know if the patient's been adherent to the regimen or not? One of the standard rules we give item writers is that we don't want to promote bad medicine, and we don't want to make this irrelevantly difficult for students that really do know this science and know this clinical medicine. You could almost, on that basis, scrutinize A a little more, because we didn't have any indication in the vignette for that.